Botulinum toxin and erythema and flushing of rosacea is really a hot topic and has been for a few years now. First of all, if we think about how toxin is postulated to act in this situation, it's actually not through the acetylcholine pathway, which is the way that toxin is used cosmetically. It's through the CGRP calcitonin gene-related peptide pathway, which is very interesting. And we're starting now to get some controlled studies. For instance, I quote in my lecture one study by Kim and colleagues, which was published in Dermatologic Surgery last year, where there was randomization of one cheek of each patient to toxin and the other cheek to saline. Now, why is this important? Because we know that needling of the skin, simply injecting with a needle into the skin, can have some effects on cytokine cascades and inflammation. So in this way, we are controlling the needling. And this controlled study showed a significant improvement in the clinical erythema assessment and the global aesthetic improvement scores for patients with rosacea when treated with toxin. There are other anecdotal case reports which predate this study in the literature, and they quite often show quite dramatic results visually. My take-home messages for anyone thinking of using botulinum toxin for patients with rosacea is that this is an intradermal injection. I showed a little video in my lecture for AAD VMX to illustrate that. These are small doses, 0.5 to 1 unit of botulinum toxin per point. I would multiply by 2.5 for my doses of botulinum toxin. 10 to 15 units per cheek, and I don't go beyond a maximum total facial dose of 80 to 100 units. Most often I'm around 50 to 60 or 70 units. That suffices. This treatment, toxin, can be useful for refractory patients suffering from rosacea. That is when other treatments have failed, or as an adjunct or in addition to other therapies. I will caution again about evidence gaps. We need more controlled studies. We also need to think about the cost versus benefit analysis, because typically this treatment will not be covered by patients' insurance. They'll be paying out of pocket. And so we must be sure that we are selecting patients for this treatment who are truly going to get a benefit that justifies the cost that they will incur.